Hey everyone, Dr. Steve here. You know it as well as I do, but most students need a B or better in A&P. But did you know that students are doing that all over the US using my Anatomy and Physiology Digital Suite as a low-cost alternative to expensive textbooks? Digital Suite delivers the key concepts of A&P with short, assignable tutor videos and a bulleted narrative study guide that not only explain the concepts of A&P, they show them happening. Combined with state-of-the-art dissection and physiology lab simulations and a vast question bank for quizzes, homework assignments, and exams, Digital Suite meets students where they are and gives them the tools to master the content. It's the perfect supplement to an OER textbook or just on its own. If you're an A&P instructor, contact your McGraw-Hill representative today and ask about Anatomy and Physiology Digital Suite. If you're a student, tell your instructor about it. There's a link to Digital Suite in the show notes of this episode. Get your B or better in A&P with A&P Digital Suite.
Insurance isn't one size fits all. That's why drivers have enjoyed Progressive's Name Your Price tool for years now. With the Name Your Price tool, you tell them what you want to pay, and they'll show you options that fit your budget. So whether you're picking out your first policy or just looking for something that works better for you and your family, they make it easy to see your options. Visit Progressive.com. Find a rate that works for you with the Name Your Price tool. Progressive Casualty Insurance Company and Affiliates. Price and coverage match limited by state law.
This episode is brought to you by Progressive Insurance. Do you ever think about switching insurance companies to see if you could save some cash? Progressive makes it easy to see if you could save when you bundle your home and auto policies. Try it at Progressive.com. Progressive Casualty Insurance Company and Affiliates. Potential savings will vary. Not available in all states.
Hey everyone, welcome back to my podcast, Anatomy and Physiology Bit by Bit. I'm your host, Dr. Steve Sullivan, coming to you from Bucks County, Pennsylvania, where I've been teaching A&P since 2002. In continuing with my episodes on diseases, conditions, and injuries, we're going to explore two of the most important neurodegenerative disorders in medicine, Alzheimer's disease and Parkinson's disease. These are conditions that many students first encounter as lists of symptoms or isolated pathology facts, but they're much more personal than that. Alzheimer's gets reduced to memory loss, and Parkinson's often gets reduced to a tremor. But both diseases are complex disorders of the central nervous system. Each involves specific anatomy, specific physiology, characteristic patterns of dysfunction, and a long clinical course that affects patients, families, and healthcare systems in profound ways. Today, we'll build the background anatomy and physiology first, then move into the mechanisms of each disease, the major causes and risk factors, the physical exam findings, lab and imaging findings, the major treatments, and finally the prognoses. I'm on my own for this episode, so I relied heavily on several sources, including the National Institute on Aging, the U.S. Food and Drug Administration, the National Institute on Neurological Disorders and Stroke, the U.S. Centers for Disease Control, and the National Institutes of Health. Once again, I want to reiterate that this podcast is for educational purposes only and in no way should be taken as medical advice. If you or a loved one is experiencing any of the signs or symptoms that you hear about today, please have them see their medical doctor as soon as possible. If you want to review the episodes on the central nervous system, you can do that, and I recommend it. It's episodes 19 through 25, and they cover the spinal cord and the brain. But I'll do a quick review of the gross anatomy of the brain now, so that way you have a good background for getting started. The human brain is the primary organ of the nervous system and is best understood in terms of several major gross anatomical regions. The cerebrum, which includes its deep nuclei and cerebral neocortex, the diencephalon, brainstem, and cerebellum. Although each has distinct structural features and functions, they work together continuously to regulate sensation, movement, thought, emotion, and homeostasis. Let's review the cerebrum, the largest part of the brain. It consists of two cerebral hemispheres connected by nerve fibers that cross the midline. These are called commissural fibers, and the largest group of them is the corpus callosum. The cerebrum's outer layer, the cerebral neocortex, is composed of gray matter and is highly folded into gyri and sulci, which increase its surface area. The gyri are the folds, and the sulci are the spaces between the folds. Beneath the cortex lies white matter, which contains fiber tracts that connect different parts of the brain to one another from all different directions. Remember, white matter is a combination of myelinated and unmyelinated axons, whereas gray matter is a combination of unmyelinated axons, neuron cell bodies, which we call neurosomas, and dendrites. These association tracts of white matter connect different parts of the brain from the anterior and posterior, from the superior and inferior, and from the left and the right. This way, different parts of the brain can communicate with one another because the nervous system is a collaborative effort of all different kinds of structures working together. The cerebrum is divided into lobes, mostly named for the overlying cranial bones. There is the frontal, parietal, temporal, and occipital lobes. There's also a deeper lobe called the insula. In general, the cerebrum is responsible for conscious thought, perception, voluntary movement, language, memory, judgment, and emotion. The frontal lobe is especially important for motor control and executive function. You may have heard that term executive function before, and it's a pretty vague term, so let me break it down for a second. Executive functions are a set of mental processes managed by the brain's frontal lobe that act as kind of an air traffic control system, enabling goal-directed behavior, planning, focus, and emotional regulation. The three core components are working memory, cognitive flexibility, and inhibitory control, which together allow for complex problem solving and multitasking. The parietal lobe covers somatic sensation and spatial awareness. The temporal lobe is for hearing and memory, and the occipital lobe is tasked with vision. Embedded deep within the cerebrum are the basal nuclei, which some people refer to as the basal ganglia. However, by definition, a collection of neurosomas and dendrites in the central nervous system is called a nucleus, not a ganglion. In the peripheral nervous system, it's called a ganglion. So calling them the basal ganglia is not technically accurate. The basal nuclei include structures such as the caudate nucleus, putamen, and globus pallidus. They are masses of gray matter involved primarily in the regulation of movement. They don't initiate movement directly, they help modulate motor output by smoothing voluntary movements, suppressing unwanted motions, and helping maintain posture and muscle tone. They also participate in certain cognitive and emotional functions through their connections with the cerebral neocortex and the limbic system. The diencephalon lies between the cerebrum and the midbrain of the brainstem and surrounds the third ventricle. Some people consider the diencephalon part of the brainstem. Others don't. Neither seems to be right or wrong. The major components of the diencephalon are the thalamus, hypothalamus, and epithalamus. The thalamus acts as a major relay station processing and directing most sensory information to the cerebral neocortex and participating in motor and associative pathways. The hypothalamus plays a critical role in homeostasis by regulating autonomic nervous system activity, endocrine function through its control of the pituitary gland, body temperature, hunger, thirst, circadian rhythms, and emotional responses. The hypothalamus is a big deal in the brain, even though it is a very small anatomical structure. The epithalamus includes the pineal gland, which secretes melatonin and contributes to the regulation of biological rhythms. Think about your light-dark sleep-wake patterns. The brainstem consists of the midbrain, pons, and medulla oblongata from superior to inferior. It connects the brain to the spinal cord and contains sensory and motor tracts of axons, cranial nerve nuclei, and centers vital for life. The midbrain is involved in visual and auditory reflexes and motor control. The pons acts as a bridge between higher brain centers and the cerebellum and helps regulate breathing. The medulla contains important autonomic centers controlling heart rate, blood pressure, and respiration, as well as reflex centers for swallowing, coughing, and vomiting. Now, you heard me mention some cranial nerve nuclei. There's actually a lot of cranial nerve nuclei in the brainstem. 10 of the 12 cranial nerves have their nuclei in the brainstem. We're not going to get into the cranial nerves here in this particular episode. You can go back to those previous episodes I mentioned earlier and review cranial nerves if you wish. The last part of the brain I want to talk about is the cerebellum. It's located posterior to the brainstem and inferior to the cerebrum. Similar to the cerebrum, it has two hemispheres and a highly folded cortex. It doesn't initiate movement, but it is essential for coordination, precision, timing, balance, posture, and motor learning. By comparing intended movements with actual performance, it fine-tunes muscular activity and helps produce smooth, accurate motions. One of the things about the cerebellum that's kind of interesting is that the cells, called Purkinje cells of the cerebellum, are highly susceptible to alcohol. So alcohol intake can decrease cerebellar function. So if you're familiar with a roadside sobriety test where they say put your feet together, put your arms out, close your eyes, touch your fingertips to your nose, that's a cerebellar function test. Walk a straight line. These are cerebellar function tests that are also roadside sobriety tests, because as alcohol diminishes the function of these cerebellar cells, you lose motor coordination. Your speech begins to slur. Your coordinated movements when you're walking begin to be a little bit shaky. And you have a hard time with precision movements like closing your eyes and touching your fingertips to your nose. Okay, so all these regions of the brain together form an integrated system that allows us to perceive the environment around us, regulate the body, and produce complex human behavior. Now remember that the nervous system depends on networks, not isolated structures. Like I said before, it is a collaborative effort. Normal cognition, memory, mood, voluntary movement, posture, and autonomic regulation all depend on neurons communicating with each other efficiently across highly organized circuits. In the cerebral neocortex, especially association areas of the frontal, temporal, and parietal lobes, information is integrated into language, judgment, planning, and memory. In the hippocampus of the temporal lobe, new declarative memories are encoded and consolidated into long-term memories. In subcortical motor circuits, especially those involving the basal nuclei, the brain selects, scales, and smooths movement. Now, one thing that is essential to this process is neurotransmitters. We know that neurons tend to communicate with one another by releasing a chemical and receiving that chemical in the next neuron. Those chemicals are called neurotransmitters. And we call that kind of communication a chemical synapse for that reason. We've got some important neurotransmitters we're going to talk about. Acetylcholine is especially important in attention and memory networks. Dopamine is especially important in basal nuclei circuits that regulate movement, motivation, and aspects of behavior. When neurodegeneration selectively damages one set of circuits more than another, the pattern of signs and symptoms begin to make sense anatomically. Okay, now that we reviewed some anatomical background, let's discuss today's diseases. We'll begin with Alzheimer's disease. This disease took my maternal grandfather back in 2001. He started having short-term memory loss in the early to mid-1990s when he was about 75 years old or so. Alzheimer's is the most common cause of dementia. It is a brain disorder that progressively impairs memory, thinking, reasoning, and eventually the ability to perform even basic daily tasks. The anatomy that matters most early on includes the hippocampus and medial temporal lobe structures, which are critical for forming new memories. Later on, it involves broader cortical association areas that support language, visuospatial function, executive processing, and behavior. This is why the earliest symptom in many patients is difficulty learning or retaining new information rather than loss of remote childhood memories. I remember my grandfather asking the same question every 5 minutes because he couldn't remember the answer, but then he would expertly recall the details of watching the New York Yankees practice at Asbury Park High School in New Jersey during World War II. As the disease spreads through cortical networks, the clinical picture broadens. Many patients have difficulty finding the right words when they're speaking, They have impaired judgment, they have disorientation, trouble handling finances or medications, getting lost in familiar places, and later, a severe loss of independence. The physiology behind memory helps explain this progression. In a healthy brain, memory formation relies on synaptic plasticity, which is the ability of synapses, the connections between neurons, to strengthen or weaken over time in response to increases or decreases in their activity. It is a fundamental, activity-dependent, and often long-lasting biological mechanism underlying learning, memory formation, and neural adaptation. It also relies on coordinated firing of neurons and the structural integrity of hippocampal and cortical networks. In Alzheimer's disease, those networks are gradually undermined by characteristic pathological changes. The classic hallmarks are extracellular beta amyloid plaques and intracellular tau tangles. Amyloid is an abnormal, insoluble protein that misfolds and builds up as fibrous deposits in tissues and organs, causing dysfunction and disease. Its abnormal accumulation contributes to plaque formation in the brain. Tau is a microtubule-associated protein. When it becomes abnormally modified, it can aggregate into tangles that disrupt neuronal structure and transport. These changes are associated with synaptic dysfunction, injury to neurons, and eventually the death of those neurons. Clinically, that translates into a progressive decline in cognition and function. It's important to say clearly that Alzheimer's disease does not begin the day a patient notices forgetfulness. Pathophysiological changes can begin years before obvious clinical symptoms emerge. Biomarkers can sometimes detect evidence of amyloid and tau pathology earlier than bedside observation alone. This is one reason modern diagnosis increasingly blends clinical assessment with biomarker evidence, particularly in specialty settings. The most widely used cerebrospinal fluid biomarkers measure beta amyloid 42, total tau, and phosphotau. Advanced imaging can identify amyloid plaques and tau tangles. In practice, this means that what used to be diagnosed only after a long clinical decline can now sometimes be characterized earlier and with more biologic specificity. So the most important question is, what causes Alzheimer's disease? The most honest answer is that it isn't just one thing. Age is the strongest risk factor. Most cases are late onset rather than early onset familial forms. Genetics matter, but genes alone do not explain every case. Researchers also study vascular health, inflammation, head injury, and broader metabolic and environmental influences. There are rare inherited forms linked to specific gene mutations, but those are not the majority of cases seen clinically. For most patients, Alzheimer's reflects a complex interplay between the biology of aging, genetic susceptibility, and other modifying influences over time. When we think about risk factors, it is useful to separate non-modifiable from potentially modifiable risk factors. Non-modifiable risk factors include older age, family history, and certain genetic profiles. Potentially modifiable factors include cardiovascular and cerebrovascular health, because vascular disease can worsen cognitive decline and sometimes coexist with Alzheimer's pathology. That matters clinically because protecting brain health is not only about neurons in isolation. It is about blood flow, endothelial health, systemic disease burden, and cognitive reserve. For students aspiring to be healthcare practitioners, this is a helpful reminder that neurology and general medicine are deeply interconnected. On examination, patients with Alzheimer's disease often appear physically normal early in the course, but careful cognitive testing reveals the deficits. Early findings may include impaired short-term memory, repetitive questioning, getting lost in a conversation, difficulty with naming, difficulty following multi-step commands, impaired abstraction, or reduced insight into one's own deficits. As the disease advances, language problems become more obvious, visuospatial impairment worsens, executive dysfunction becomes disabling, and behavioral symptoms may emerge. Later stages can involve severe dependence, gait impairment, swallowing difficulty, and the loss of the ability to walk or eat independently. There are also behavioral and psychiatric symptoms such as agitation, anxiety, wandering, sleep disturbance, depression, and aggression may also occur and often become major drivers of the burden on caregivers. My family and I observed almost all of these with my grandfather. He was among the kindest people I've ever met, but toward the end of his disease, he became aggressive toward my grandmother to a point where he had to be in a care facility. Also, one time, my family and I went to Disney World. I was in my 20s. My younger sister was graduating from college in Florida, so we decided to make the trip into a vacation. My grandparents came, my other sister and her kids came, and we went to my sister's graduation, and then we all went to Disney World. At one point, we were all waiting for the bus to leave the park to go to the hotel we were staying in, and no one knew where my grandfather was. He had wandered off. There were no cell phones. This was 1996. And eventually, we just saw him walking on over. It was a little scary. Luckily, it worked out. But again, the wandering was evident. There are also important laboratory findings with Alzheimer's disease. Routine blood work doesn't diagnose Alzheimer's directly, but it is essential in the workup of cognitive decline because clinicians have to rule out reversible or contributing causes such as thyroid disease, vitamin deficiencies, infection, metabolic abnormalities, the effects of medications they're taking, or some other systemic illness. More disease-specific laboratory information may come from biomarkers in cerebrospinal fluid and increasingly from select blood-based biomarkers in evolving clinical practice and research settings. The major teaching point is that lab findings in Alzheimer's are less like a single definitive blood test and more like a layered process. Routine labs to exclude diseases that mimic Alzheimer's and biomarkers to support underlying pathology when appropriate. When it comes to imaging, those findings are also understood in layers. Structural imaging with MRI is often used to exclude other causes of cognitive decline and may show patterns of atrophy, including involvement of the hippocampus and the neocortex. PET scans can detect amyloid and tau pathology in selected situations. The PET in PET scans stands for positron emission tomography, and what they do is they detect increased metabolic activity. That's why they're often used for cancer, because you can see the increased metabolic activity of tumor cells. The advanced imaging in Alzheimer's does not replace clinical judgment, but can strengthen diagnostic confidence and clarify the biology of the disease. Treatment for Alzheimer's disease can be divided into symptomatic treatment and disease-modifying treatment. Symptomatic treatment has long included medications that support cholinergic transmission, such as cholinesterase inhibitors. These treatments do not cure the disease, but they may help some patients maintain function or reduce symptoms for a period of time. Non-pharmacologic care is equally important, like structured routines, environmental support, caregiver education, management of sleep and behavioral triggers, and attention to safety, nutrition, and fall risk. More recently, anti-amyloid immunotherapies have entered practice for selected patients with early Alzheimer's disease. There are FDA-approved therapies intended for patients with mild cognitive impairment or mild dementia stage disease, if amyloid pathology is confirmed. If amyloid pathology is in fact confirmed. These therapies are not for every patient, and they carry meaningful risks, especially amyloid-related imaging abnormalities, often abbreviated ARIA, which is why MRI monitoring is part of management. For students, the key takeaway is that Alzheimer's treatment is entering a new era, not a cure, but a move toward earlier biologically targeted intervention in select patients. The prognosis in Alzheimer's disease is progressive decline. How quickly that happens varies from patient to patient, but overall the trajectory is one of worsening cognition, worsening loss of independence, and eventually major functional disability. Patients often die not from the protein aggregates themselves, but from complications of advanced neurodegeneration such as immobility, infections, malnutrition, aspiration, or the cumulative burden of frailty. This is why early recognition, long-term planning, caregiver support, and goals of care discussions matter so much. Alzheimer's is not only a memory disorder, it is ultimately a systemic, life-altering illness with neurologic roots. I can attest, and I assume many of you have experience with this as well, it is a horrible disease for both the patient and their loved ones. The old saying is that with Alzheimer's, you lose someone twice. First when their mind goes, and then when their body goes. There was a point in time when my grandfather no longer recognized anyone. That's a really tough one to take.
Did you know Fast Growing Trees is America's largest and most trusted online nursery with thousands of trees and plants and over 2 million happy customers? Whether you're planting fruit trees, adding privacy, brightening things up with flowers, or bringing in houseplants, Fast Growing Trees has it all. Even better, they can help you find options that are right for your climate, your space, and lifestyle. Click Order Grow. Every plant arrives healthy with the Alive and Thrive guarantee straight to your door. So if you're ready to get planting, this is the moment. Right now, they have great deals on spring planting essentials, up to half off on select plants. And listeners to our show get 20% off their first purchase when using the code WWO at checkout. That's an additional 20% off. Better plants and better growing at fastgrowingtrees.com using the code WWO at checkout. Fastgrowingtrees.com, code WWO. Now's the perfect time to plant. Let's grow together. Use WWO to save today. Offer is valid for a limited time. Terms and conditions apply. Go to growingfasttrees.com for details.
Okay, now let's turn to Parkinson's disease. Parkinson's is classically described as a movement disorder, but just like Alzheimer's, that shorthand is incomplete. Parkinson's disease is a progressive neurodegenerative disorder in which neurons in specific brain regions weaken, become damaged, and die. The most clinically important physiology involves the basal nuclei, especially dopamine-producing neurons associated with the substantia nigra of the brainstem's midbrain, and their projections into motor circuits. Dopamine normally helps balance direct and indirect motor pathways that facilitate desired movements and suppress unwanted movements. When dopamine levels fall, movement becomes harder to initiate and scale appropriately. The result is not paralysis, but a cumulative effect of multiple disorders of movement: bradykinesia, which means moving slowly, rigidity, tremor, and postural instability. The mechanism of Parkinson's disease centers on the degeneration of dopamine-producing neurons and the pathologic accumulation of Lewy bodies and Lewy neurites. Lewy bodies and Lewy neurites are both abnormal aggregations of the protein alpha-synuclein, constituting what's known as the Lewy-related pathology in Parkinson's disease and another condition called Lewy body dementia. Lewy bodies are spherical inclusions found inside the cell body of neurons, while Lewy neurites are thread-like inclusions found in the axons and dendrites. As dopamine signaling falls, basal nuclei output becomes abnormal, leading to slowness and stiffness. This is why Parkinsonian patients may have a reduced arm swing, a shuffling gait, difficulty turning, masked facial expression, which means a loss in facial expression, creating a blank, fixed gaze on things, softened speech, and trouble initiating movement. Importantly, Parkinson's is not only motor. Non-motor symptoms can include constipation, loss of smell, sleep disorders, mood changes, fatigue, autonomic dysfunction, and later cognitive impairment. In some people, certain non-motor features may emerge years before classic motor findings become obvious. As with Alzheimer's disease, the causes of Parkinson's disease are multifaceted. Most cases are sporadic rather than caused by a single known mutation, although genetic forms do exist. Researchers continue to examine interactions among age, genetic predisposition, environmental exposures, and cellular processes such as mitochondrial dysfunction, oxidative stress, and abnormal protein handling. Risk rises with age, and the disease is chronic and progressive. As aspiring medical professionals, it is worth noting that neurodegenerative disease often resists a single cause narrative. Instead, multiple vulnerabilities accumulate until circuits can no longer compensate. In a physical exam, the primary motor findings of Parkinson's disease are bradykinesia, resting tremor, rigidity, and later on we see difficulty maintaining posture. Bradykinesia is the essential feature. A patient is slow to initiate and perform repetitive movement, and movements may diminish in amplitude. Let's talk about what a resting tremor is and how it differs from intention tremor. Resting tremor means the involuntary shaking is typically when the limbs are at rest. Intention tremor is when the shaking intensifies when the patient begins to make precise movements. Resting tremor often begins asymmetrically, classically in one hand. Sometimes you'll hear the term pill-rolling tremor. This is an early sign where there is an involuntary circular motion of the thumb and index finger similar to rolling a pill. Rigidity may be felt as increased resistance to passive movement. Gait may become shuffling with reduced arm swing, stooped posture, difficulty turning, and festination, which means the steps increase in speed but decrease in stride length. Like I said earlier, facial expression may be reduced, blinking decreased, and speech softens. The asymmetry of findings early in the disease is often an important clue. Laboratory findings in Parkinson's disease are different from those in many systemic illnesses because there is no routine blood test that confirms idiopathic Parkinson's. Labs are often used to exclude conditions that mimic Parkinson's rather than make the diagnosis directly. Some of the conditions that mimic the effects of Parkinson's are multiple system atrophy, progressive supranuclear palsy, corticobasal syndrome, and dementia with Lewy bodies. There are also secondary causes to Parkinsonism. This means something else is resulting in similar signs and symptoms of Parkinson's. Some antipsychotic drugs and anti-nausea drugs can cause Parkinson-like symptoms. Other secondary causes are normal pressure hydrocephalus, fluid on the brain, small strokes, and brain tumors. Diagnosis remains primarily based on history and neurologic examination. Response to a medication called levodopa can also support the diagnosis in appropriate settings. Levodopa replaces lost dopamine in the brain and reduces the early signs and symptoms of Parkinson's. Levodopa crosses the blood-brain barrier and converts into dopamine. Dopamine itself does not cross the blood-brain barrier, so it can't be used directly to treat Parkinson's. So the bottom line is that for Parkinson's, laboratory testing is usually supportive and exclusionary rather than definitive. Imaging in Parkinson's disease is also a supportive tool rather than the sole diagnostic standard. Brain MRI may be used to rule out alternative structural causes of symptoms like strokes and brain tumors. And in some cases, dopamine transporter imaging with a DAT scan can help support the diagnosis by showing reduced dopaminergic function. But this is important. Parkinson's disease is still diagnosed mainly from the clinical picture, not from a single scan. Imaging becomes most useful when the diagnosis is uncertain or when distinguishing Parkinsonian syndromes from other conditions. Treatment for Parkinson's disease is centered on restoring dopaminergic function or modulating related circuits. The cornerstone medication, like I said earlier, is levodopa. And it's usually prescribed along with carbidopa, which helps limit peripheral metabolism and side effects like nausea. There are other medications, depending on the patient and stage, that can improve symptoms, but they do not replace the lost neurons or stop disease progression. Over time, many patients experience motor fluctuations or dyskinesias related to long-term treatment and the evolution of their disease. For some patients with disabling motor symptoms that are not adequately controlled with medication, deep brain stimulation may be considered. Deep brain stimulation, or DBS, is a surgical treatment in which electrodes are implanted into specific brain targets and connected to a pulse generator. It can reduce symptoms and, in select patients, may reduce medication requirements. It's not a cure, and patient selection matters enormously, but it is one of the most important examples of circuit-based therapy in clinical neuroscience. Finally, the prognosis in Parkinson's disease is also progressive, but the pattern differs from Alzheimer's disease. Many patients live for years with gradually increasing motor disability and accumulating non-motor symptoms. Early in the course, treatment may provide substantial symptomatic benefit. Later, gait freezing, falls, swallowing problems, autonomic dysfunction, sleep disturbance, hallucinations, and cognitive decline may become more prominent. The disease itself is usually not fatal in a single dramatic way. Instead, disability grows over time, and complications such as falls, aspiration, infections, immobility, and cognitive deterioration contribute heavily to morbidity and mortality. So how do we compare these two diseases, Alzheimer's and Parkinson's disease? They're not really that related, except that they are both diseases of the brain and associated with age. But I put them together in this episode because they are so enormously common neurological diseases of age. So let's compare the two. Alzheimer's disease primarily begins as a disorder of cognition, especially memory and higher cortical functioning, because it preferentially damages hippocampal and cortical networks. Parkinson's disease primarily begins as a disorder of movement because it preferentially damages dopaminergic basal nuclei circuits. Alzheimer's disease is defined pathologically by amyloid plaques and tau tangles. Parkinson's is associated with dopaminergic neuron loss and alpha-synuclein pathology. Alzheimer's disease diagnosis increasingly incorporates biomarkers such as CSF studies and amyloid or tau imaging, whereas Parkinson's diagnosis remains primarily clinical, with imaging used selectively to support or clarify the picture. Alzheimer's treatment includes symptomatic cognitive drugs and, for select early-stage patients, anti-amyloid therapies, whereas Parkinson's treatment centers on dopaminergic replacement and circuit modulation, including deep brain stimulation in appropriate cases. Both diseases are progressive. Both profoundly affect patients and caregivers. And both remind us that anatomy and physiology are not abstract academic subjects. They are the foundation for understanding human disease. As we close up this episode, here's the deeper lesson for students entering healthcare. Neurodegenerative diseases ask us to think on multiple levels at one time. We need cellular biology to understand protein aggregation and neuronal death. We need gross and functional neuroanatomy to understand why one disease causes memory failure and another causes bradykinesia. We need clinical reasoning to interpret exams, imaging, and laboratory data. And we need compassion because these disorders unfold over years and they alter identity, independence, and relationships. When you study Alzheimer's disease and Parkinson's disease, you're not just memorizing plaques, tangles, tremors, and dopamine. You are learning how breakdown in neural systems becomes visible in the life of a patient, a friend, a family member, a loved one. And that, ultimately, is what anatomy and physiology should teach us: structure, function, dysfunction, and the human meaning of all three. Thank you once again for listening. I hope this podcast is helping you get your B or better in A&P. Good luck, be well, and I'll talk to you next time. Anatomy and Physiology Bit by Bit is a production of Minus 55 Media and is hosted by the Believe Network. Please take the time to rate the podcast and leave a review. You can also check out the content I post on Instagram and YouTube as @StudentHelp4AP. That's StudentHelp, the number 4, AP. Special thanks to my family, Bucks County Community College, and McGraw-Hill Education, where your instructor can find Anatomy and Physiology Digital Suite, my low-cost, tutor video-based digital learning solution for anatomy and physiology currently being used at several colleges and universities. If your instructor isn't using Digital Suite, let them know about it. The link is in the show notes.
If you like the show, please take a moment to rate, review, and subscribe. It really does help the show to grow. Thank you for listening.